Now let's dive into the blood work. Standard RA panel includes RF or rheumatoid factor, anti-CCP or anti-citrullimated protein antibodies, ESR or erythrocyte sedimentation rate, CRP or C-reactive protein, complete blood count, liver function tests for medication monitoring, and kidney function tests for medication monitoring. This is adequate for diagnosis and basic medication monitoring, but it misses the metabolic dysfunction driving the disease. Let me show you a real patient's comprehensive panel and what each marker tells us. Autoimmune markers show RF at 62 IU per milliliter, positive above 20, and anti-CCP at 248 units per milliliter, strongly positive above 20. These confirm RA diagnosis. Higher anti-CCP predicts more erosive disease. Inflammatory markers show CRP at 4.8 milligrams per liter, elevated, should be below 1, and ESR at 48 millimeters per hour, elevated, should be below 20. Active inflammation. But we need to know why inflammation persists. Complete blood count shows hemoglobin at 10.2 grams per deciliter, anemic, should be above 12 in women, MCV at 78 femtoliters, low, should be 80 to 100, and RDW at 16.8%, elevated, should be below 15. Microcytic anemia with high RDW. This suggests combined iron deficiency and anemia of chronic disease. Now here's where it gets interesting. Iron studies show serum iron at 38 micrograms per deciliter, low, should be 60 to 170, TIBC at 412 micrograms per deciliter, elevated, should be 250 to 400, transferrin saturation at 9%, very low, should be above 20, and ferritin at 86 nanograms per milliliter, falsely normal due to inflammation. True iron deficiency masked by inflammation. Ferritin is an acute phase reactant. It goes up with inflammation even when iron stores are depleted. This is why we check transferrin saturation and TIBC, not just ferritin. The patient needs iron supplementation, but her rheumatologist never addressed it because ferritin appeared normal. Thyroid panel shows TSH at 3.9 milli-IU per liter, high normal, should be below 2.5 for optimal. Free T4 at 1.1 nanograms per deciliter, low normal, should be above 1.3. Free T3 at 2.4 picograms per milliliter, low, should be above 3.0. And anti-TPO antibodies at 124 IU per milliliter, positive, indicating Hashimoto's. Subclinical hypothyroidism with autoimmune thyroiditis. This is contributing to fatigue, weight gain, and immune dysregulation. But because TSH is under 4.5, conventional medicine says thyroid is normal. Vitamin D and cofactors show 25 OH vitamin D at 14 nanograms per milliliter. Severe deficiency should be above 60. Intact PTH at 78 picograms per milliliter. Elevated should be below 40 with optimal vitamin D. Ionized calcium at 1.04 millimoles per liter, low normal, and RBC magnesium at 3.8 milligrams per deciliter, low, should be above 5.0. Severe vitamin D deficiency with secondary hyperparathyroidism. Magnesium depletion preventing vitamin D activation. This is the vitamin D resistance we discussed earlier. Metabolic markers show fasting glucose at 104 milligrams per deciliter, pre-diabetic, should be below 100. Fasting insulin at 19.8 micro-IU per milliliter, insulin resistance, should be below 7. HOMAIR at 5.1, insulin resistance, should be below 2.0. And HbA1c at 5.9%, pre-diabetic, should be below 5.7%. Insulin resistance and pre-diabetes. Chronic inflammation is driving metabolic dysfunction. This creates more inflammation in a vicious cycle. Lipid panel shows triglycerides at 242 milligrams per deciliter, elevated, should be below 150. HDL at 38 milligrams per deciliter, low, should be above 50. And triglyceride to HDL ratio at 6.4, very high, should be below 2.0. Atherogenic dyslipidemia. This patient has high cardiovascular risk, not just from RA inflammation, but from metabolic syndrome. Liver function shows ALT at 52 units per liter, elevated, should be below 35. AST at 48 units per liter, elevated, should be below 35. And GGT at 67 units per liter, elevated, should be below 40. Alkaline phosphatase is normal, liver inflammation, possibly from methotrexate, but also from metabolic dysfunction and insulin resistance. Additional markers show homocysteine at 14.8 micromoles per liter, elevated, should be below 8. Methyl malonic acid, elevated. B12 at 285 picograms per milliliter, low normal, should be above 400. And folate normal on folic acid supplementation. Functional B12 deficiency despite normal serum B12. The elevated homocysteine and methyl malonic acid confirm this. This impairs methylation, worsens neurological symptoms, and contributes to cardiovascular risk. And again, her rheumatologist never checked these markers, never connected them, never addressed them. She's been told her disease is controlled, while 7 distinct metabolic dysfunctions go completely unaddressed. When we look at this blood work as a whole, here's what we see. This patient has active RA with high antibody titers, iron deficiency anemia masked by inflammation, subclinical hypothyroidism with Hashimoto's, severe vitamin D deficiency with magnesium depletion, insulin resistance and prediabetes, metabolic syndrome with atherogenic dyslipidemia, functional B12 deficiency with hyperhomocysteinemia, and liver inflammation. Her rheumatologist is treating items 1 and 8, RA and liver monitoring for methotrexate. Items 2 through 7, completely ignored. Yet these metabolic and nutritional dysfunctions are directly contributing to her immune dysregulation, inflammation, and poor response to treatment. Let's go deeper into why thyroid matters. Prevalence of thyroid disease in RA patients is 2 to 3 times higher than the general population. The most common pattern we see is TSH 3.0 to 4.5 milli-IU per liter, high normal. Free T4, low normal. Free T3, low, which is the most important marker. And anti-TPO positive indicating Hashimoto's. This is subclinical hypothyroidism with autoimmune thyroiditis. It's subclinical because TSH isn't above the lab cutoff for diagnosis, but it's not optimal. Thyroid hormone, specifically T3, is essential for regulatory T cell development, proper immune tolerance, mitochondrial function in immune cells, gut barrier integrity, and vitamin D receptor expression. When T3 is low, Tregs don't develop properly. Th17 cells become dominant. Immune dysregulation worsens. Studies show that optimizing thyroid function in RA patients improves disease activity scores, reduces inflammatory markers, and enhances response to DMARDS. Yet conventional rheumatology rarely addresses this. They see the joints, they treat the joints. The thyroid? Normal. Iron deficiency in RA is common and multifactorial. First mechanism is anemia of chronic disease. IL-6, the master inflammatory cytokine in RA, triggers hepcidin production in the liver. Hepcidin blocks ferroportin, the iron export channel on enterocytes and macrophages. This traps iron inside cells, preventing it from getting into circulation and into hemoglobin. Second mechanism is true iron deficiency from chronic gut inflammation, acid reflux medications impairing absorption, and chronic blood loss from NSAID-induced gastritis. Third mechanism is increased iron utilization. Your bone marrow is trying to produce red blood cells in an inflammatory environment that suppresses erythropoiesis. It needs more iron just to maintain inadequate production. The result? Microcytic anemia with low transferrin saturation, but falsely normal or even elevated ferritin. Iron deficiency worsens RA outcomes. It causes severe fatigue independent of inflammatory burden. Impaired mitochondrial function in immune cells, altered T cell differentiation favoring Th17 over Treg, and poor response to DMARDs. Correcting iron deficiency is not straightforward. Oral iron is poorly absorbed when hepcidin is elevated. We often need intravenous iron formulations in RA patients with functional iron deficiency. But most rheumatologists don't check transferrin saturation. They see normal ferritin and miss the iron deficiency entirely. In the next part, we break down the 6 types of RA. Most patients are handed methotrexate and told they have RA. But seropositive, seronegative, post-viral, drug-induced, these behave completely differently and respond to completely different approaches. We also cover the alarming pattern we are seeing with GLP-1 inhibitors triggering seronegative RA in patients from the US and the Middle East. And if you want the complete picture, the full 2-hour RA masterclass is linked in the description below and pinned in the comments.